Our patient is a 75-year-old female with comorbidities of hypertension and bronchial asthma. She presented with class 3 dyspnea from 4 years. ECG showed normal sinus rhythm. On echo, there was severe aortic stenosis, bicuspid aortic valve with gradients of 105/68 with preserved EF. CAG showed normal coronaries. Considering her age and comorbidities, we planned for transcatheter aortic valve replacement. We did a CT according to TAVR protocol. She had a bicuspid aortic valve type 1A with fusion of right and left coronary cusp with a raphe which also was calcified. The annulus was 21 mm with area of 352 mm square. The coronary heights, the left coronary height was 10 mm, the right was 11.5. The right SOV diameters were less 24 mm. The virtual valve to coronary RCA was only 2.4 mm. There was aortic valve calcification, annular calcification extending into LVOT also, more in the NCC and also extensive calcification in the arch of aorta. Considering all this, the plan was to do a transcatheter aortic valve replacement with a balloon expandable valve with size of 23 mm. The femoral arteries, bilateral femoral arteries, and the iliac vessels were normal in diameter. There was no calcification. We took 2 arterial axes on the femoral side using a micropuncture needle. Left was our primary axis. Proglide pre-deployment was done. The punctures were clean. And we also put a TPI lead from the left femoral vein axis. Aortic valve was crossed with straight tip wire using AL2 catheter. And pictal angiogram was done. The gradients were recorded. The peak-to-peak gradient was 58 millimeters of mercury. Pre-dilatation was done using 16 into 40 mm Mammoth balloon with pacing at 180. After this balloon dilatation, we could see that there was a faint RCA flow, and considering VTC of 2.4 mm in the RCA, we planned to park a stent in the proximal RCA. And also the RCA height was a little high, so we used the JR catheter itself for that. We parked a stent of 3.5 to 29 mm biomeme des. A 23 mm Merrill valve was positioned across the aortic valve and deployed at 180 mm pacing. Immediately after the deployment, we didn't have any minute to take an injection. Patient developed suddenly bradycardia, CHV hypertension. Of course, we did a check angiogram which showed severe free AR, and there was no flow in the RCA. Immediately, we stented the RCA. Stent was deployed at 11 atmospheres. Severe AR was persistent. We suspected frozen leaflet might be the mechanism of this severe AR. Aortic valve was post-dilated again with the same Mammoth balloon. 1 cc extra inflation was done. After this, we did a check angiogram using the pigtail aortogram. There was no AR. 2D echo was also done to confirm. RCA stent was patent. The AR index was 38.6. We thought the procedure is successful and we will close the femoral axis, but to our surprise, again, patient developed sudden hypertension, bradycardia, collapsed, CPR initiated. We had good LMCA flow, we had no AR, we did a 2D echo, there was no cardiac pericardial effusion, there was no tamponade, but patient was throwing VT, there was recurrent VTVF. We had to defibrillate her for around 20 times. This was the recording. For around 20 minutes, we actually had to do CPR for her. In the meantime, we did IABP, we intubated her, we gave her inotropes, suspecting LMC occlusion. We did an angiogram. To our surprise, there was LMC occlusion at the ostium. So they thought of leaflet prolapse or query thrombus. So LMC was hooked with EVU catheter. We did pre-dilatation with 2 into 12 mm NC balloon with the CPR with ongoing VT. There was flow re-established in LMCA after the pre-dilatation. LMCA was stented with 3.516 biomeme stent. After this, there was STEMI 3 flow, both in LCA and as well as RCA. There was no AR. Left femoral arterial axis was closed with 6 French angioseal device. So the check angiogram after the procedure from the contralateral side from the right femoral artery showed that there was a narrowing at the puncture site. Vessel remained patent, vessel pulses were felt well. We attributed this due to stitch effect because of the proglide. And we didn't do anything because vessel pulses were felt, and we left for follow-up. So after this, patient was shifted to ICU. She did not gain her consciousness because of prolonged hypoxia. We also wanted to rule out a CVA. CT was done. We found that there was a left cerebellar infarct with hydrocephalus. We started her on anti-edema measures. mannitol. Patient did not regain her normal sinus rhythm. She was still in CHB. So after 48 hours, we had to put her DDDR pacemaker. And to rule out progression of infarcts, we did do an MRI brain. MRI brain showed a large MCA infarct, which infarct progressed. From the day one at 48 hours, it increased. It was posterior circulation and anterior circulation, both infarcts, dense infarcts were found with supratentorial hydrocephalus. She had a very stormy course in the hospital. She had hyponatremia, AKI. Around 15 to 20 days, she was there with us. We did her tracheostomy. We took care of the tracheostomy. We decannulated her after 15 days, and she was sent home. So at 3 months follow-up, she is now ambulatory. She is doing good work. She can talk. She's doing normally functioning aortic valve and normal cognitive function. So the take-home message is the complications can be multisystemic. We had in this patient from vascular injury to valve thrombosis, everything we had like vascular injury, conduction disturbances, paravalvular leak, stroke, acute kidney injury, except cardiac tamponade, annular rupture, everything possible complication was seen in this patient. So the key is pre-procedural planning is the key. Early recognition saves life, and multidisciplinary heart team approach is the key role which actually helped in management in this patient. And long-term follow-up also helps to prognosticate these high-risk patients. Thank you.